Thank you for inviting me to celebrate with you this year's International Women's Day. For those of you who aren't familiar with TDR, it is the special program for research and training in tropical diseases. It is co-sponsored by UNICEF, UNDP, the World Bank, and the World Health Organization, and it is based at WHO headquarters in Geneva. We support innovative global health research by strengthening the research capacity of disease-affected countries and by promoting the translation of evidence into interventions that reduce the burden of infectious diseases and build resilience in the most vulnerable populations. Understanding gender dimensions has always been a critical area for TDR. We know that gender roles, norms, and relations intersect with other axes of inequality, such as age, experience of racialization, social status, or disability, and influence why and how health is shaped in a specific way. They also influence vulnerability to infectious diseases, access to healthcare, and also how people experience and respond to disease and treatment. This is relevant in infectious disease implementation research because otherwise we would ignore those social dynamics, including gender-related dynamics that take place at community level and influence how or for whom a health implementation strategy works. We support in TDR intersectional gender analysis in research to generate new evidence to inform health policy and practice, as you can see in the video that follows.
Gender, sex, and their intersections with other social variables influence everyone's health. Understanding how and why is important for decision makers and health practitioners to improve the health of their citizens. Intersectional gender analysis is the process to identify how gender power relations interact with other social variables to affect people's lives and how it creates differences in their health needs and experiences. It also analyzes how policies, services, and programs can help to address these differences.
This year's theme for International Women's Day is Choose to Challenge, which calls for celebrating women's achievements and raising awareness and taking action against inequalities. I think gender inequality is one of the most critical global issues to be addressed and one of the biggest barriers and threats to progress in global health and in development. Worldwide, major gender-related disparities exist and persist between women and men researchers. And globally, women account for only about 30% of researchers, according to UNESCO. And so although this estimate probably masks some national and regional variations, evidence shows that women's participation is still lower at leadership and decision-making levels. TDR has supported pilot schemes to enhance career opportunities for women scientists in infectious diseases. One of our objectives in strengthening capacity for research is to understand, to unpack the barriers holding back women scientists in LMICs. A good example is the Clinical Research and Development Fellowship. This is a program designed for scientists from low and middle income countries to work with pharmaceutical and research institute partners to learn how to conduct clinical trials, to develop drugs, to develop vaccines and diagnostics. However, we realized that women were significantly underrepresented among the applicants to this scheme. And in fact, in 2016, they made up only 19% of all applicants. So responding to the need for greater women's participation in this mid-career fellowship, TDR organized a crowdsourcing contest to solicit feedback from the public and to identify feasible solutions for this scheme. And some of the proposals that were implemented included, for example, improving communication and information through social media linked to existing women's associations and women's networks, showcasing previous TDR's fellows through profile stories, mentoring activities, and also making the fellowship a bit more flexible. For example, by dividing the program into 2 phases to allow fellows to return to their home institutions and visit family for a period of time. Because in reality, women disproportionately bear the burden of caregiving, and so this may complicate considerations moving away from their country for an entire year. In terms of results, these ideas were implemented as part of the 2018 fellowship application cycle, and the number of eligible women applicants increased from 11 in 2016 to 48 in 2019 and 53 in 2020. Well, still many challenges and many gaps remain, but our experience suggests that we need to develop and implement more innovative ideas to strengthen gender equality in global health training. And it's also important to note that evaluating training fellowships typically involves surveys, and while they are helpful to evaluate program activities, they do not capture perspectives of individuals who did not apply. And so our experience suggests the importance of exploring opportunities for reconfiguring institutional policies related to training programs that can enhance gender equality. And lastly, I'd mentioned that increasing the voice of women in global health training programs and learning from their experiences is key because women are not a homogeneous group. Our experience suggests this is relevant to designing research and training programs in LMICs, and that more research is needed since there is not one, but multiple realities in which women live, in which women develop their careers. And in our analysis, women cannot be treated as if they all have the same priorities, the same experiences, backgrounds, or perspectives. And so it's important to remember that gender intersects with other axes of inequality, with other social stratifiers, under systems and under structures of power. And this influences why, when, and if women apply. So thank you for allowing me to share some of these experiences and efforts with you to contribute to gender equality in global health. And I look forward to the panel discussion that follows. Thank you.